Well, greetings to each of you on this first Monday in February. Today is February 5th, 2024, and I am Seth Stander, the Community Aging Specialist for the Hope and Healing Center and Institute in the department we call here CARES. CARES is an acronym for Caregiving, Aging, Resilience, Ethics, and Spirituality. And the department is directed by Dr. Peggy Dettermeyer, and together we offer a variety of educational programs, individual consultations related to every part of the acronym for CARES, support groups related to the acronyms that CARES embodies, and more. And one of those offerings is today, the beginning of our 4-session series, Aging with Grace, where we will, over the next 4 weeks, cover today healthcare rights and responsibilities. Following that, we will address legal considerations having to do with aging, either in place or in long-term care or otherwise. Understanding those living options in greater detail, and ways in which we pay for aging, not just aging in place, but of course, aging under either non-ordinary or extraordinary circumstances. So we are recording each of these sessions, these 4 sessions that we will hold on today, the 5th, and then on the 12th, the 19th, and the 26th of February. We invite you to go ahead and, if you, after today's session, haven't already signed up for our subsequent sessions, to go back to our website, to hhci.org, and click on the Events tab, which will take you to those additional dates and allow you to register just as you did today through Eventbrite. HHCI is here to address the mental health needs of a variety of demographic groups, and CARES mirrors that responsibility to our community by focusing in on our growing aging population and those who care for them. So, as I mentioned before, consultation, community education, focusing on the hopes and challenges of aging, on bioethical concerns, the caregiving hopes and challenges that one may experience, and navigating the journey of grief. We are grateful to be offering you, thanks to generous underwriting and a very robust philanthropic department, all of our programming free of charge. And again, hhci.org is our website if you would like to see more of what we offer and the various resources that are archived under the Resources tab, which is accessible through our homepage. I'm going to go ahead and share my screen and bring up today's slides and move us first and foremost into the question of, and this is assuming that my slides cooperate with me. There we go. What are the traditional duties of medicine? I think it's important for us to start here as we consider healthcare rights and responsibilities, to have the beginnings of a common understanding of the purpose of medicine as a pathway towards healthcare literacy, which in turn allows us greater autonomy and the opportunity for advocacy for others or for self-advocacy when needed. And as you can see here on the slide, we're talking about the ideas, and these have been around for generations, articulated in ancient scripture all the way to contemporary text, that medicine is designed to, when possible, prevent disease, to restore function, to prolong life, to relieve suffering, and, when appropriate, because we are all mortal, to attend the dying. And in each and every one of these instances in which we look at these very basic overarching areas where medicine informs and hopefully improves our lives, we're looking to each one of these being carried out with the greatest of dignity and with respect for personal autonomy. So, with that in mind, we're going to focus this morning on different categories of healthcare rights and responsibilities. And I put these together into five components: financial components, the treatment plan components. When I use the term information, here I'm talking about information about those who are tasked with your care or the care of your loved one, and the policies and procedures that those who are tasked with your care, those who are helping you with regards to your financial rights and obligations, and the treatment plans that those who are caring for you or your loved one are tasked with, are done so in an appropriate way. And then we'll go ahead and we'll spend some time, additional time, focused on advanced directives, how they can inform not just the care that we receive from professionals, but can be an articulation of values for those who are supporting us, and can help them champion our rights, our dignity, our autonomy, if we are not able to articulate those rights and needs and wants for ourselves. Uh, I have observed that when it comes to contemporary healthcare, where in fact, even as it's become more complex, providers are required to share more and more detailed lists of these rights and responsibilities, that very often we tend to gloss over these. This is not a critique on you or anyone else in society. I know I have certainly, if I'm installing an app onto my computer or onto my iPhone, I've gone ahead and scrolled right on through on many an occasion what's called the EULA, the End User License Agreement, because I simply wanted to get to the point where hitting the accept button would allow the download of that app. But when it comes to what providers give us in terms of detailed information about consumer rights, consumer responsibilities in a healthcare system, I think it's important for us to dive deeper, even though it may take more time. And depending on the circumstances, we are very often not at our best when we approach the healthcare system. So let's focus first on what seems like the most straightforward category, that is financial rights and responsibilities. It may seem simple, but it is, of course, the most expensive of any of the options that we will be considering today in terms of taking the opportunity, making the choice to research our rights and understand, and making the choice to fulfill our responsibilities when it comes to, again, financial, treatment plans, information about the people caring for us, policies and procedures related to our care, and our responsibility to anticipate what we would want if we find ourselves unable to speak for ourselves and are in various types of medical states. But let's focus first on the financial, as I said before. Now, with health insurance, the financial obligations that individuals have, it's really a straightforward matter of what rate your insurance carrier has agreed to pay your provider. And of course, whatever is left over is yours to cover, whether it is a deductible, whether it is a copay, and so forth. Without health insurance, you're going to have a list of detailed prices that the provider is to give you. And if they don't give you that right away, you have the right, of course, to request an itemized, detailed list of all possible charges that you will incur when you are receiving healthcare in a particular institution. And of course, there is the responsibility for covering what you actually use. Regardless of whether you have health insurance that has a deductible or a copay, or whether you're not currently utilizing health insurance, or there are other categories, underinsured, out of network, all of these, what they all have in common is that there is an out of pocket cost to you. And with that, I will say, first and foremost, advocacy for oneself or for a loved one takes the form here of negotiation. Being upfront with the healthcare institution about your ability to self pay either the entire cost if you lack healthcare insurance, or a portion of that cost if some of it is covered by your health insurance in network, out of pocket costs that result from what's left after that coverage that's been negotiated. We want you to negotiate by being upfront about your ability to self pay, scrutinizing those itemized charges, and insisting on getting them before you pass over any payment. And if it is truly the case that you will go through financial hardship or worse to make sure that you offer an alternate amount, providers will prefer to receive partial payment versus no payment at all, and going through the whole process of collections. If you're upfront with them, I think you will find that ultimately what is an impossible situation may become a merely expensive one. And I am not making any light of how expensive healthcare is in today's world. Rather, I'm reminding you that, like anything else in life, this too is negotiable. Transparency matters on both sides of the rights and responsibilities equation. So let's move into the question of your rights and responsibilities when a treatment plan is offered to you, which is why the header for this slide says follow treatment plan or not. Everyone has the right, and one would argue the responsibility, to follow or not follow the treatment plan that has been provided to you by the people in the healthcare system you've engaged for care. The provider needs to explain to you, and if necessary to your proxies, if that is who is advocating for you, in detail what they plan to do for you and what the benefits but also the potential complications of that treatment plan may be. And of course, you have the right to ask questions, and following that, to accept or decline some or all of what the provider is proposing. Now, yes, there are emergent circumstances where ultimately care is going to be provided before you may have the opportunity to fully participate in the treatment plan. So we're talking primarily about non-emergent situations, although I would argue that with advanced directives, someone speaking for you with advanced directives of yours in hand, if you cannot go ahead and speak for yourself, has quite a bit to say, even in an emergent situation, about what in fact you are willing or your loved one is willing to accept based on what their advanced directives say they will accept when it comes to heroic versus comfort care. And we'll talk a lot more about that in just a few minutes. We ultimately have the right to also go ahead and receive continuity of care. That is follow up with the provider who has provided us with our initial care, and also to make sure that we are having anyone else involved in continuity of care. Ideally, you all have primary care physicians who would want to go ahead and see what a urgent care, hospital stay, whatever the case may be, resulted in, so that they can go ahead and make sure that you are continuing to recover in an appropriate and timely manner. Having equal access to treatment. Wow. Talk about one of life's great social issues. Obviously, a work that is still very much in progress. And so when we talk about accessing equal care, what we're really talking about at this point is making sure that advocacy in the treatment room is taking what may have been known by previous generations as a more patriarchal or parochial implicit trust in medical authority, and replacing it with a model in which we collaborate by asking and expecting to receive appropriate feedback after general information about our treatment plan is provided to us. The bottom line is that none of this treatment, barring emergent circumstances, should take place without informed consent. And if a provider were to attempt to do so without informed consent, there needs to be a compelling medical and or legal reason to do so, or there will in fact be legal consequences. The overarching category of information that I alluded to earlier, here I want to break it down into what we have the right to expect in terms of information. And this does go to also the flip side, our responsibility to act on our rights and advocate for ourselves and others to ensure that said information is provided in an appropriate and in as complete a manner as possible. And that starts with knowing the identity of those professionals who are tasked with your medical care. Knowing their credentials is important too. Receiving the detailed information that that healthcare institution is to provide to you about your rights as a patient there. It needs to be in a written format that you can easily read and understand. And by the way, if it's in a language that isn't native to you, you need and have the right to access interpreter services, be they spoken interpreter services, translation of written information if for some reason it's not available in a language that you understand, sign language interpretation. And all of this is at the cost of the healthcare institution. Again, they're required to make sure that you understand the detailed information about your rights as a patient or your loved one's right as a patient, that they are obliged to provide to you. You have the right to, of course, receive information about various treatment options. And I say this not to belabor the obvious, but rather to remind you, and this goes back to the financial considerations as well as the efficacy, the effectiveness of healthcare itself. There is often more than one way to treat a condition. The easiest example I can think of is that there are prescriptions of varying price levels that very well may provide similar, if not equal, treatment based on the condition that you are experiencing. It's important to know what is brand only. In other words, it's not off patent yet and made into a generic, and what is already generic and may accomplish the very same goals with regards to your recovery based on the condition that you are experiencing, or to manage chronic care conditions, which very often tends to be where prescription costs skyrocket. You have the right throughout all of this to access your medical records. When you leave a healthcare institution, I recommend that beyond having your primary care physician or your loved one's primary care physician notified that you have been in the hospital, not only because they might have privileges there and can visit you, but also because if your primary care physician's office asks for the complete medical record of your stay, it is not going to cause you to incur a charge, which if you ask for the very same information, there is a strong possibility that you will be charged per page. I will remind you that if you don't need every single page of a medical record, um, and are comfortable having all of that information sent to your primary care physician after your healthcare stay elsewhere, I think it's important for you to remember, if you haven't already done so, that most primary care systems will have some type of online portal so that you can see, either in summary or sometimes in more detailed format, the records of your acute healthcare stay. And ultimately, that may be enough for you to have a better understanding, working in concert with your primary care physician. This goes back to continuity of care, about how to either continue your recovery or manage your chronic condition. Understanding the policies and procedures of a healthcare institution that is providing you with care really comes down to one major responsibility and a lot of rights. The responsibility is right here in the center. Follow the institution's rules and please be considerate. Even though you may be having a terrible day, possibly one of the worst days of your life or in the life of someone you love, it is important to understand just how stretched medical and other clinical staff are in healthcare institutions today. They have operating rules and procedures for a reason, and to whatever extent it is possible for you to follow them, please do so with grace. And you will find that the kind word to the overworked very often in healthcare institutions goes a long way towards not only continuity of care in the facility and when you leave the facility in terms of communicating those medical records in a timely fashion, but also in terms of respecting the rights that surround this responsibility graphically. You do have the right, as we've mentioned, to know the policies and procedures of the healthcare institution. You absolutely have the right to be free from any type of abuse or neglect or financial exploitation that might occur in that institution, unless there is a compelling documented reason why you should be restrained. And there are specific rules and circumstances that follow the use of restraints in acute care facilities like hospitals. You should be free from said restraints. In terms of preserving your self-image, we are talking about your dignity. We are talking about not just your physical appearance, but also your sense of self-esteem. You have not checked your dignity away when you enter a healthcare institution. There may be reasons for people to be in your personal space in ways that simply do not happen when you are at home. But again, this is not a normal time. Having said that, sensitivity to how you operate under quote unquote ordinary circumstances is important. Engaging in ethical issues that may arise with regards to your care, whether it makes sense to go ahead and to follow an aggressive path, or whether a mixture of aggressive and comfort care, or whether comfort care alone is the most appropriate way to manage your symptoms, if in fact you are in a situation where either recovery is possible, improbable, or simply not going to happen. And if there are questions about the ethical principles of what is called beneficence, following the good in a situation, non-maleficence, not causing harm. We've mentioned autonomy. Here I'll place it as an ethical principle, and ultimately justice, going back to, for example, self-image, and dignity, and equal access to care. If you find that there are questions that you are observing, they need to be raised, and not just with the primary team responsible for yours or your loved one's care, hospitals maintain formal and informal ethics committees. And this is absolutely your right to ask for an ethics consult. By the way, outside of the hospital, CARES, our division here at the Hope and Healing Center and Institute, maintains its community equivalent, what is referred to by us as CHECS, which is the Community Healthcare Ethics Consultation Service. And we use small teams, in addition to Peggy and myself, both trained and experienced in bioethics, in order to go ahead and to assist when it comes to similar types of ethical concerns involving the efficacy of care, of managing chronic care, and looking at comfort care as we approach the latter stages of life. Finally, when we talk about confidentiality and privacy, privacy in terms of non-invasive entry into the space that you are temporarily occupying as a patient, confidentiality in terms of not having people who don't need to know, learning from the people who are providing you care about the experience of caring for you, let alone what it is that you require care for. Everyone is entitled to have a bad moment when you are having a troubling experience, and being a patient in a hospital counts. So your privacy goes back to your dignity, preserving your self-image, and the confidentiality part is, yes, clinical staff do need to go ahead and to appropriately share with one another, very often in interdisciplinary team meetings, about the protocols of your care. But whether or not you're having a good day, a bad day, your appearance, your smell, your demeanor, all of the above, your dignity needs to be protected throughout this process. So there are limits to what professionals caring for you can and should share with one another. And now we're going to spend some time talking about the last bullet point, the advanced directive section. And here it's the graphic is straightforward enough in terms of you have a right to have advanced directives, and we're going to talk about that, of course, in detail, and you have a responsibility to provide those tasks with your care with said advanced directives so that they can be better informed as plans of care, treatment options, and such are being formulated, again, with your understanding and participation, either on your own behalf or on the behalf of someone else. So let's backtrack to 1976. In 1976 was a very traumatic year for the Quinlan family. Um, Karen Ann Quinlan, whose name you might recognize depending on your age and knowledge of history, um, unfortunately entered and never exited what we now call a persistent vegetative state. Her parents took her to the hospital, of course, hoping that aggressive care might prove effective, and over time, unfortunately, learned that it would not. Um, they reached a point where they realized that there was no quality of life remaining for Karen Ann in her vegetative state, and after great deliberation, they asked the hospital to remove the ventilator that was keeping her alive. The hospital at the time had no standing to do so, and so they refused. Karen Ann's parents, understandably so, went to court to go ahead and to ask that a legal order be sent to the hospital to remove the ventilator from their daughter. And they won that particular case. The court ruled in her parents' favor, and the hospital then slowly weaned Karen off of the ventilator. And wouldn't you know it, Karen Ann Quinlan survived that process and remained in a persistent vegetative state. This time in a nursing home, she was discharged from the hospital soon thereafter for 9 more years before her death. Now, you may be wondering, did they miss something in all of this? And the answer is yes, because at the time, the parents of Karen Ann Quinlan did not think to ask the hospital or the court about removing artificial nutrition and hydration and their status as forms of treatment for someone in a persistent vegetative state, and therefore 9 more years of existence. I'm not sure what we can say about quality of life for Karen Ann Quinlan. Continued. Ultimately, advanced directives began to be discussed as the public became informed about the gap in patient rights on this very issue when tragedies might befall us. So ultimately, should we lack the ability to speak for ourselves, starting in 1991, with the Advanced Directives Act passed by Congress, the federal government has given us the opportunity in each state to identify through that state's advanced directive paperwork who we are, what we like to do, control that we like to have, goals that we have, and things for which we hope when it comes to the issue of prolonging life. Now, it is important to note that as the state of medicine and as people's understandings of what constitutes a good death evolve, and they are evolving, no question about that, we will see a situation where, depending on the state in which your advanced directive is drafted, that deals with these issues of integrity of self, how aggressive we want to get based on the circumstances with regards to medical care. Ultimately, how we want to envision the good death, because we are all mortal and we may be facing in that particular moment said mortality. If you are in a state in which medical assistance in dying, also known by other names such as physician-assisted suicide, is legal and you go to another state where it is also legal, it will be honored. If you go from a state where you have provisions in place in your advance directives for medical assistance in dying and similar terms, and you go to a state where it is not legal, all the other aspects of your advance directive should translate without a problem. But if that particular piece is not legal in the state where you now live or find yourself passing through and hospitalized, then there will be limits to what is transferable in that particular case. We will see in the future whether or not that remains the case or whether there will at some point be an impetus for the fact to update categories within the umbrella of advanced directives. But I am not here to predict the future, merely inform you of the present. So let's talk a little bit about the potential goals of care that, like the other bullet points I just fleshed out, will help inform us as we detail our advanced directives. Ideally, we will have whatever ails us cured, and we'll stay in control during that process, thereby avoiding premature death, maintaining or improving function if that has been compromised as a result of the disease, injury, or ailment that befalls us, see our lives prolonged, relieve our suffering. Ultimately, all of this assumes that what we are facing can either be cured or safely managed while allowing us to maintain our function, a high quality of life, our comfort. But again, all of us are mortal. Don't want to prolong life beyond our capacity for suffering. But if that suffering can be relieved and our function and quality of life can be maximized, we might have a great deal to say about what steps we ask different types of healthcare providers to employ based on the stage of life in which we find ourselves. Now, there are going to be situations where we are dealing with multiple goals of care that apply simultaneously and, in fact, could be contradictory based on the circumstances in which we find ourselves. Let me give you an example, and this is what also covers the third bullet point here, which is that some of those multiple goals of care are going to take priority over other goals. Think about chemotherapy, or nowadays chemotherapy or immunotherapy, coupled sometimes with or sometimes without radiation as a treatment for cancers. You are going to feel side effects from any or all of the above treatments. But if said treatments have the possibility to control or ideally eradicate the types of cancers that you might be facing, you are going to experience not just a relief of suffering after a time, but you're also going to avoid premature death. You're going to see ideally a cure, if not maintenance of a disease, and you are going to see an improvement in your function and certainly a relief from suffering. And we are getting better and better in many ways at providing an environment of care that can indeed lengthen the quality of life, and in many ways can preserve or improve the quality of life. Both matter, but both still have limits. Therefore, as you might imagine, depending on an individual's preference and whether the people they love agree or disagree with them, or whether the people caring for them agree or disagree with them, there are also going to be ethical quandaries that accompany technical progress. being able to specialize in different areas of medicine, being able to improve the survival opportunities when under anesthesia and undergoing surgery, being able to enter and have a greater chance of leaving an intensive care unit. This is amazing. And depending on how poor our health condition is, before engaging in any of the above, the specialization, the surgery and anesthesiology, the use of intensive or critical care units, we have to have a realistic understanding of whether or not we are preserving quantity over quality. Because again, both matter. And if there is an imbalance, perhaps there is also an ethical quandary that needs to be dealt with. Another example that's listed here in the bullet points is that organ failure doesn't automatically equal death. Dialysis is probably the most widely accepted example of how we have normalized improving one's quantity and ideally quality of life through treatment for, in this case, kidney failure, or what is also known as end-stage renal disease. The end part, of course, of what could have occurred before, chronic kidney disease. Medicaid covers dialysis. This did not happen overnight, but as demand ballooned in this country, as the cost of dialysis and the portability of dialysis improved, it became obvious that for citizens who qualify under the definition of medical and financial need, that it needed to be covered, not just by private insurance, but again, for those who have the financial and or medical need through Medicaid itself. The definitions and the limits of artificial nutrition and hydration, depending on where you live and the healthcare system that is caring for you, its origins, whether they are religious or secular based, you are going to find yourself with some fascinating ethical quandaries. If you find yourself in a situation where the body may no longer be benefiting from artificial nutrition and hydration because it is approaching the end of life, and yet the concern about discomfort from withdrawing nutrition and hydration needs to be addressed, not just ethically, but also in terms of what pharmacologically can be done to give a person comfort as they approach the end of their days and their ability to benefit from artificial nutrition and hydration diminishes or ceases altogether. And then we talk about heart and lung assists, not just the technology that exists today, but thinking about the use of everything from artificially created organs to the fairness, or if you will, the inherent unfairness that you may perceive in donor lists themselves. Remember, we talked about equal access to care as both an important healthcare right and responsibility subject, and the justice element of that as a fundamental concept in bioethics. So we're going to continue to see these roll out as the years go by. Healthcare literacy is probably one of the most important things that one can do for oneself and the people they love as you prepare advanced directives, because it gives you the opportunity to practice outside of a high stress environment, aka hospitalization. And your understanding of not just the nomenclature that's going to be used in that acute care facility, but also an understanding of the options that working in concert in a non-emergent circumstance, you get to discuss with those healthcare providers. So, taking a look at this list, I encourage you not only to go ahead and to talk to your primary care physician or anyone in a position to properly educate you about each one of these, but to take to heart the general descriptions that I'm about to provide over the next few minutes. I mentioned that the likelihood of a person leaving an intensive care unit, an ICU, sometimes referred to as a critical care unit or CCU, has improved over time. It's still important to understand that if a person is fragile enough medically to be placed in such a unit, they are already statistically at around a 10% likelihood of dying while in the hospital, regardless of the care provided. Having said that, the important counterpoint is that by providing a better patient to nurse ratio, the highest it typically goes, except under extreme circumstances, is 3 to 1. The more robust treatments that are going to be prescribed by the physicians who are engaged in yours or your loved one's care, they're going to be more robust, which comes to the emergency interventions. Should you stop breathing? Should your heart stop beating? And understanding the difference in terminology that is being used around you. And again, as you craft advanced directives for yourself or help those you love craft their own. Remember, when we talk about CPR, we are talking not only about compressions, we are also talking about cardiac drugs, we are talking about defibrillation, and we are talking about intubation using breathing tubes or ventilators. So if one is inclined to accept CPR, you will be what is often called full code, and understand that despite the potential for injury, especially to your sternum and the rest of your chest, because if it's going to work, CPR is ultimately going to cause some physical injury, in addition to the side effects that may occur based on the cardiac drug, defibrillation, and ventilator use, but that it stands a chance of restoring life. Will it stand a chance of restoring total function? That depends on the age, physical condition, and timeliness of the CPR in all of its aspects. The most famous public example in recent memory was of Buffalo Bills player Damar Hamlin, who collapsed and required CPR on the football field, and after he was resuscitated successfully, underwent intensive treatment in order to restore him to full function. He also happened to be a premier athlete and a young adult man who is able to go ahead and find himself motivated and fully involved in his own recovery and physical rehabilitation that followed recovery from that cardiac arrest. Somebody who is 75, 85, 95, and has various other conditions that they are also dealing with chronically, or other acute conditions that have brought them to the hospital, may not fare the same. The statistics, depending on how you read them, because as Mark Twain said, there are falsehoods, lies, and damn statistics. We can make statistics prove whatever point we care to make. So I could go ahead and just stop by telling you that CPR, as administered, whether by people in the field or in a hospital, has maybe a 10% or better chance of working. The truth is, depending on, again, the other factors I just mentioned, it stands a far greater chance, but that has to be on an individual basis, not as a trend. So keep that in mind. Now, alternatives to that, include the do not resuscitate or DNR order. There are in hospital and out of hospital do not resuscitate orders, and they have their own set of parameters, but primarily what they mean is don't use chest compressions, don't use cardiac drugs, don't use defibrillators, do not intubate, don't use don't use breathing tubes, but go ahead and use chest compressions, use cardiac drugs, use defibrillation. And I neglected to mention for the DNR piece, you would not use ventilation in a DNR either. Allow natural death ultimately is comfort measures only. It parallels in some way the do not resuscitate order, although modifications to all of these are possible. But if one goes ahead and puts an A and D into their packet of advanced directives, what they're really saying is not only do we not want the most invasive measures taken, again, compressions, drugs, defibrillation, breathing tubes, we also don't want artificial nutrition and hydration. We don't want anything, really, that prolongs the natural dying process. When we put these together, very often they are details under the category of what is referred to as a living will, or the form directive to physicians and family or surrogates. That is the way it is entitled here in Texas and in many other states as well. And it doesn't vary much in terms of its name, but the colloquial name, regardless of what state you find yourself in, is a living will, in which all the things I just mentioned are articulated in greater detail. It's important as you form these to also have an understanding of the difference between a terminal illness, that is to say, a condition in which death is expected within 6 months. Your prognosis is that poor, versus an irreversible illness, where chronic treatment options are available, perhaps to a certain extent. Beyond that extent, they will not be effective, because there is, in fact, no cure. We're talking about ALS, Parkinson's, and so forth. The issue of heroic measures, do everything. Very often when someone says, I want you to use heroic measures, I want you to do everything, this is where you're going ahead and you are saying, this individual, whether it's me or a person I love, full code, everything possible. You don't stop at anything in order to go ahead and to preserve their quantity and ideally quality of days. As opposed to palliative care, which exists on a continuum. There are aggressive measures that one can take. We talked about chemotherapy, radiation, immunotherapy for people dealing with various cancers as an example. Well, palliative care exists to go ahead and to manage the symptoms that accompany those types of treatments. But palliative care very often is first looked at as comfort care for the end of life. And one category of that is hospice, which is a type of palliative care that is reserved for those who have received a terminal diagnosis for which the prognosis is 6 months or less. Typically, it occurs at home, and you work with a healthcare team that is designed to help meet physical, psychosocial, spiritual, and emotional needs. There is always more that could be said about such overarching categories as these. But as I said before, please take advantage, especially if you have yet to create an advanced directive, of your own medical community as a resource to help you better understand what I've described in general terms today and what you may find doing your own research. Ultimately, as we review our goals, as we review our priorities, um, we need to make sure that advanced directives stay current with any changes that we have in our health status, especially if we are dealing with a chronic and advancing illness. Whether we have changed our setting of care from I went to the hospital, I'm coming home to recover and or do outpatient therapy, to I've entered a long-term care facility and I require assistance with my activities of daily living, or ADLs, which we will talk a lot more about when we get to the understanding living options topic of this course. And all of it, including the last bullet point here, treatment preferences, needs to be updated as your logistical, physical, psychosocial, spiritual, and emotional priorities change. So if you need some talking point examples, I want to have the best care possible until the day that I die. I want to live meaningfully. I want to remain independent. I want to establish boundaries. I would like to die with dignity at home or wherever the question marks represent for you. Each one of us is going to answer this in a particular way, although there are trends. And it's important for us not to compare our answers as being better or worse than the answers of others, but rather to understand that the human condition is an ever-evolving situation, just as the stages of life that we experience allow us to better understand what reasons we're here in the first place. And it's important for us to have a sense of why we are here in this world in order to help inform the language that talks about care that either keeps us in this world or keeps us comfortable until our bodies cease to function. Who gets to make these decisions? Who gets information about these decisions? And how do we talk about the information that's related to our plans of care, our advanced directives, our priorities? Well, that, as I mentioned, is going to be based on the values, the preferences, the clinical circumstances that we face, and it will be influenced by the medical information that your care team provides you. Look, let's say, God forbid, that sooner rather than later, you are going to be evolving into experiencing moderate to late stage Alzheimer's disease. Do you, based on that information and your own values and preferences and wishes for yourself and your family across the generations, wish to do everything possible to maintain your quantity of days? Or do you want to employ the types of palliative care measures which won't end up lengthening your days, but will keep you comfortable and may end up preserving your estate, your savings, because it's a priority to you to have those pass along to the next generation, whether it's to send grandchildren to college or help other loved ones pay off the mortgage of a house. Who knows? There's no right or wrong to this. There is only the open, honest assessment of what you expect out of life based on the clinical circumstances you face. So when we talk about our life goals and our healthcare goals, we ultimately need to go ahead and recognize that not every person wants to live beyond their ability to perceive the world around them or perceive it in a way that they find meaningful, and to respect it. And where legal, to help them to make decisions about how and when they choose to say goodbye to this world. That may be something you agree with. That may be something you vehemently disagree with, and that's okay. I'm not here to advocate one position or another, but rather to make you aware by saying out loud that depending on where you live in this country or on this planet, these ranges of decisions that are life extending to life limiting exist on a vast continuum and an ever evolving one. Now, it's important to make sure, and this is something we're going to discuss under the legal section of this course, that anyone who is making decisions about initial advance directives or modifications to their advance directives has decision-making capacity and competency. They have to be able to understand and make their own decision, use the information rationally when they're formulating a decision tree, and appreciating the consequences of the decisions that they make. Ultimately, these need to be communicated before, ideally, I should say, before hospitalization occurs. And the ideal format for that is the written advance directive or set of directives based on how much information has been put in writing and where it needs to be signed and witnessed, notarized, etc., has done so. But if we lack that, then we rely on the stories that a patient has told us, their loved ones, about their wishes, their general values and beliefs. We look to our own observations as to how they've lived their lives and what would they want moving forward given the situation they find themselves in. And if necessary, we go ahead and we get the help of professionals who can help us better organize our thoughts to determine what is, based on a desire to preserve autonomy and dignity of that loved one, their best interest determination. The tools that are listed here: medical power of attorney, directive to physicians. Again, I've referred to that as colloquially the living will. We haven't discussed a declaration for mental health treatment, but we have talked about the out-of-hospital form of the DNR, the Do Not Resuscitate Order, as opposed to the in-hospital created DNR. You can see on this, and you're all going to, again, receive the recording as well as the slide deck for each of these particular courses in this series. You can see on here what the purpose is and also what the legal requirements are to properly execute such a document. In the state of Texas, medical powers of attorney, which designate a decision maker if you are no longer able to make medical decisions for yourselves, a directive to physicians, talking about choices in case of terminal or irreversible conditions, and a declaration for mental health treatment, talking about in advance about what would happen and to what extent you would want certain therapies if you find yourself in an emergent mental health situation, if you are in crisis and require, very likely, inpatient mental health treatment as a result. You can see that Texas has tried to make the completion of these documents as easy as possible by only requiring 2 witnesses as opposed to a notary, and that copies of these documents are acceptable as you present them to the appropriate healthcare authorities. Now, you do need to go ahead and to have a physician sign off on an out-of-hospital do not resuscitate order, in addition to either witnesses or a notary. But that, again, is a very much achievable goal. in terms of making sure that these core tools, and we haven't talked about durable power of attorney, that is giving someone the ability, if you are unable, to go ahead and to handle pragmatic affairs, especially financial. But these in particular, as opposed to a durable power of attorney, which needs to be crafted by an attorney, and we'll talk more about that in the section on legal considerations. Ultimately, you have the ability to complete these today, most of them. Again, might take a little bit of time to find a physician to sign off on that out of hospital DNR. If you are inclined at this stage in life to put one forward for signature, most of us aren't. Most of us are full code because we're in good health and of a certain age level, but there may reach a time where you want that document, in which case it's doable. That's the important thing to recognize from this. None of these tasks are arduous to perform. Now, I will leave it for you, for the sake of time, to look on your own when you receive the slide deck at the next couple of slides, which are a detailed list of questions, discussion points for when you experience a serious or life-limiting illness. Things you can ask your doctor, not just about the trajectory of your illness, but also about the pros and cons of different treatments, what it might be like to die from this disease, and how important is it for me to consider palliative care measures, and if so, of what kind? Just as I will leave for you to look at your leisure at this slide, because although there are less talking points, I think that these are all questions that beg for conversations internally, as well as with the people you love and trust. What activities or capacities make my life worth living? What are my greatest fears and regrets? And given that my time might be short, how do I want to spend it? And that's coupled with, ultimately, the hopes and rites of passage as we inevitably find ourselves coming closer to our mortality. Knowing that we have left a good emotional legacy, that we have enjoyed the time left to us in this world, that we have had what we consider adventures, and that we have left our loved ones in as good a shape as possible, holistically speaking. So knowing oneself, know thyself, is critical. Thinking about your plans well before they're needed, getting them formalized with directives and other appropriate documentation, and talking with family members, and by extension, anyone in your life who you may at some point entrust with decision-making ability on your behalf, should you become unable to do so. These last few slides, first, a slide on some resources that might help you access further information about everything I've discussed today. And again, we'll encourage you to go ahead and to look at this when you get a copy of the slide deck. And ultimately, our contact information for both Peggy and myself. We are happy to provide individual family consultation on anything that we teach, or under the umbrella of caregiving, aging, resilience, ethics, and spirituality. Again, the acronym CARES is important here because it very much helps those who might seek our services, and we encourage you to talk to us if you're curious or in need, to understand the parameters under which we might assist you directly or through referral. We encourage email when it comes to scheduling in-person, virtual, or telephone consultations. So I'm going to stop sharing my screen, and ultimately, as I see the time, I'm going to take a quick peek to see if we have any questions or comments? It looks like the chat screen is clear. Generally, our programs, Aging with Grace, begin at 10 a.m. Depending on the length of materials for each week, we will end sometime between 11 and 11:15, which we appear to be right around the middle of, as I read 11:09 on my computer screen. So I want to thank you for spending your hour plus with me today. And I hope that you will go ahead and register for any or all of the remaining 3 sessions. Again, you can go to our website, hhci.org. You can click on the events tab and then register after you've clicked on the particular lessons that are offered through Eventbrite for the continuing sessions. And again, the series is complete, you will receive recordings and the slide decks. I hope each of you have as kind and as gentle a week as possible. And please feel free to reach out to us if you desire individual consultation. You take care.